Hello, my name is Harry Erba. I'm a professor of medicine at the University of Alabama at Birmingham, and there I serve as the director of the Hematologic Malignancy Program. In this video, what I'd like to do is tell you about your blood and hopefully help you understand some of the changes that might be happening in your body due to various diseases or due to chemotherapy and treatments that your physician may be giving you. We will then also look at blood counts so that you may be able to interpret the reports that you and your physicians will be seeing. So let's get started with a description of the tissue blood. Blood is actually a liquid tissue where cells are suspended in a liquid. The liquid is called plasma. It's not just water. That plasma carries a lot of very important proteins that are important in various aspects of human biology. For example, plasma contains antibodies or immunoglobulins that help fight infection. Plasma contains clotting proteins that will help form a clot after platelets in your blood, which we'll be discussing, first form a blood clot. There are also a number of other chemicals and electrolytes that are in the plasma and circulate throughout the body. But suspended in that plasma are different types of blood cells. And we can look at these blood cells under the microscope when blood is smeared out on a glass slide. So let's start by talking about the most abundant blood cell, and that is the red blood cell, shown here on this photomicrograph of human blood. So you can see the most abundant cell here is the red blood cell. It has a very characteristic round shape and a central area that looks a little paler because of the shape of the cell. What you'll also notice is if you compare the red blood cell to these cells up here, lymphocytes and neutrophils that we will be discussing shortly, red blood cells do not have that dark purple inclusion. That's the nucleus. So red blood cells leave the bone marrow where they have formed without a nucleus. This is important because red blood cells without a nucleus will only survive in the body for about 100 to 120 days. And then they undergo senescence and they die. The organ that's responsible for clearing worn out red blood cells is the spleen. And that is one of the functions of the spleen, to get rid of those old worn out red blood cells, which means that as those red blood cells are destroyed, new ones will have to be made. Since the lifespan of a red blood cell is about 100 days, it makes sense that every day your body reproduces 1% of the red blood cells in it. Well, how much is that actually? Well, in every microliter, millionth of a liter, and a liter is about a quart, there are 5 million red blood cells. Considering that we have 5 liters of blood in our body, that means we have 25 trillion red blood cells circulating throughout our body at any one time. Since the red blood cells only live for 100 days, that means every day about 1% of that red blood cell mass has to be reproduced. And so of the 25 trillion red blood cells, 250 billion red blood cells have to be formed daily. And that's one of the functions of your bone marrow, which we'll be talking about shortly. The function of these red blood cells is predominantly to carry hemoglobin, which carries oxygen throughout the body. When the number of red blood cells is low, we say that a person is anemic or has anemia. When the number of red blood cells is high, which can occur in a number of malignant and non-malignant states, we say that the person has erythrocytosis or polycythemia. Let's now turn to the white blood cells. The function of the white blood cells is predominantly in the defense of the body. They fight off invading pathogens. A pathogen is some organism that is trying to get into the body from the outside and cause disease, pathology. And so white blood cells, their function is in some way to defend the body against those pathogens. The most abundant of these in the blood is typically the neutrophils or segmented neutrophils. I think one of the difficulties my patients often have in understanding what we're talking about is we typically have many names for the same thing. So we will call these segmented neutrophils or polymorphonuclear neutrophils or just neutrophils. They all mean the same thing. These cells have the primary responsibility of fighting off bacteria and fungi that are trying to get into the body. And there are a number of places where our internal body is interfaced with the external world, besides our skin. For example, in the nasal passages and the sinuses, in the respiratory tract, where air comes into the lungs, in the entire gastrointestinal tract, and then, as I said, the skin. The function of the neutrophils is to go to those sites of the body, the respiratory tract, the gastrointestinal tract, and the skin, and the general urinary tract, which I didn't mention before, where outside pathogens from the outside world are trying to get into the body. These cells form our first defense against those invading pathogens. And so a neutrophil actually has very little function in the blood. I like to think of the blood as the highway that the neutrophils take to get from their point of origin, which is the bone marrow, into those tissues where they will form secretions. Because of that, a neutrophil actually spends very little time in the blood, less than a day, and on average is probably only a few hours after its production and release from the bone marrow that it can be found in the blood before it gets into those tissues. And so again, what you're hearing me say is that because these neutrophils go into the tissues to fight infection, and there they will do their job and ultimately die in those tissues as they get rid of bacteria and fungi at that interface with our dirty external world, it's no wonder that the bone marrow has to constantly be producing new neutrophils as well. But neutrophils, if they are high in number, can be seen in situations where a person is fighting infections. That would make sense. A stimulus is produced somewhere in the body of an infection, telling the bone marrow to make more white cells. We call this neutrophilia. On the other hand, a situation where our patients may be subject to spontaneous infections and unusual infections is when the number of those neutrophils is low, either because of chemotherapy drugs that they are receiving or because of the very disease processes that affect the bone marrow where neutrophils are made. When the neutrophil count is low, we call that neutropenia. And when it's very low, below a certain number, which I'll get to later, we call it absolute neutropenia. The importance of that absolute neutropenia is the level at which people are prone to develop infections that others who have normal immune systems, normal neutrophil counts, will not get, such as fungal infections, especially of the lungs, or certain bacterial infections as they move from the colonic flora, the bacteria that live in our intestines, into the bloodstream. So absolute neutropenia is something that can lead to complications of infection, and absolute neutropenia can be due to the disease processes affecting the bone marrow or also to the treatments that we give for various cancers. But neutrophils are only one type of white blood cell. The next most abundant white blood cell is shown here in these slides as well, and that is the lymphocyte. As you can see, these are a bit smaller than segmented neutrophils, about a little bit larger than a red blood cell, and most of the cell has a nucleus in it, that very deep purple, and there's just a very thin rim of cytoplasm around it. There are actually various types of lymphocytes in the blood that we call B cells and T cells. based on where these cells are produced in the body, but also more importantly, what their functions are. B cells ultimately become cells called plasma cells, which create those antibodies and immunoglobulins, which I mentioned earlier, that float around in the plasma to kill bacterial or viral infections as they get into the body. The T cells, they have a number of other functions, including getting rid of viral infections, but also in some sort of immune surveillance that helps suppress cancers from developing. Finally, the B and the T cells, especially the T cells, can become unrestricted in their attack, and instead of attacking foreign pathogens that are trying to get into the body, can attack normal tissues, and we call those autoimmune diseases. Autoimmune diseases such as lupus or rheumatoid arthritis are due to abnormal function of those lymphocytes, specifically the T lymphocytes. And there are a few other types of white blood cells which we're going to focus on when we look at what a blood report looks like. Lymphocytes actually can live many, many months, if not years. In fact, some of these are memory T cells, which have the job of remembering exposure to a prior pathogen, and then when a person is re-exposed, reactivating again. And then finally, in terms of the cellular components of blood, there are the platelets. Platelets are very tiny. You could see these tiny purple dots on the photomicrograph. Each of them is maybe about a third or a quarter the size of a red blood cell. Again, they don't have a nucleus, and their job is to form a blood clot. If there is a break in a blood vessel wall from trauma, for example, their job is to go to that break in the vessel wall and form the first plug to prevent blood loss. So we call that primary hemostasis. When a person has a low platelet count, we call that thrombocytopenia. When the platelet count is high, which can occur in a number of inflammatory conditions, iron deficiency, or as part of overproduction in the bone marrow, certain cancers of the bone marrow, we call that thrombocythemia or thrombocytosis. Again, unfortunately, multiple names for the exact same phenomenon. So again, a low platelet count, thrombocytopenia, can be due to diseases of the bone marrow, leading to inappropriate or low levels of production, or to the chemotherapy drugs that you may be receiving. Thrombocytosis or thrombocythemia is a high platelet count, often associated with too many blood clots forming in the body. But that's the subject of another discussion some other time. Now, platelets also serve a very important function, as I mentioned, of clotting the blood, and our bodies are always subject to some degree of trauma. And so it should be no wonder that these platelets are always involved in trying to prevent blood loss. If we didn't have platelets, we would be forming bruises in areas of minimal trauma. And in fact, that's exactly what happens to patients with low platelet counts. Very low platelet counts can lead to bruises where you are just leaning against something, or just because of the hydrostatic pressure of the blood sitting in the legs as you stand, you can get little red spots from blood loss from blood vessels called petechiae when the platelet count is very low. So these are critically important constantly in preventing blood loss from occurring. And because of that, again, since they don't have nuclei, and so similar to red blood cells, you should understand that these platelets must be constantly replenished by the bone marrow. And in fact, the lifespan of each of those platelets is only about a week, somewhere between 5 and 10 days. So again, these are the components of the blood, the cellular elements of the blood. The most abundant, the red blood cell. When they are low in number, we call that anemia, or our patient is anemic. And when they are high, we call that either polycythemia or erythrocytosis. Function of the red blood cells: carry oxygen When they are low, people suffer from symptoms of anemia like headache, shortness of breath, palpitations, their heart racing when they exert themselves, and fatigue, of course. There are various types of white blood cells, and they all have different functions. The two most important that you will hear about from your physician are the segmented neutrophils, which are important in fighting bacterial infections and fungal infections. When those are very low, we call that neutropenia, and when they are below a specific number, which we're going to come to, we call that absolute neutropenia, when people are particularly susceptible to infections. When they are high, we call it neutrophilia. Typically, that's a response to some infection. Lymphocytes, another type of white blood cell, very important in making antibodies and fighting off various viral infections, immune surveillance against cancers developing. These cells live much longer. And then finally, the platelets, tiny anuclear, in other words, cellular elements without a nucleus that live only about a week and whose function is to form the primary hemostatic plug, big words for a blood clot, when there's a break in the blood vessel wall. When the platelet count is low, we call it thrombocytopenia, and when the platelet count is high, we call it thrombocytosis or thrombocythemia. And then, of course, all of those cells are floating around in a liquid called plasma, which contains clotting proteins, immunoglobulins, albumin, a protein that keeps fluid inside your blood vessels, electrolytes, and other important components of the blood that we don't have time to discuss at this point. So let's move on now. So with that primer on what is in the blood, I now want to turn to the blood counts that will be performed. As you know, one of the common things that your physician will do at visits and in between visits, during therapy, after therapy, is to check the health and the status of your bone marrow by checking the blood counts. And this is the simplest biopsy that we can do. It's a blood draw. And so a tube of blood is removed and the cells, the liquid is passed through a machine that has been developed that can count each of these cellular components. And we get a printout of that point in time, what's in that tube of blood at any one time. So let's look at what a blood count report will look like. And again, we'll call this a CBC or a complete blood count or just blood counts. What you're looking at here are blood counts from one of my patients. And you'll see that there's a lot of information that's here in the blood counts. Now, having already told you about what are the components of blood, you're starting to see on the left-hand side of this slide some familiar names, like white blood cells, red blood cells, the hemoglobin, which I mentioned is the protein inside of red blood cells, platelets, and then the various types of white blood cells below that, neutrophil and lymphocytes, which are the most abundant, and then some others that are less abundant, accounting for only about 10% of the blood cells there, monocytes, eosinophils, and basophils. Now these are each given abbreviations, and so I want to just start with that. Let's get to the top. White blood cell, WBC. The machine will give a result, 9.2, which really means 9,200 white blood cells per every microliter. Again, a microliter is a millionth of a liter, a tiny drop of your 5 liters, 5 quarts of blood that you have. So there are 9,200 white blood cells per microliter. Now again, one of the things that can sometimes confuse my patients is some nurses and physicians will report these numbers as what comes exactly off of that report, as, for example, in this case, 9.2, and others will call it 9,200 because they're referring to per microliter. Okay, but these are basically the same number. Now, there's no flag on this one. The flags would be for H for high and L for low on most of these reports. And what I don't show you here on this report, and this is by design, is I don't show you the normal range. And the reason I don't show the normal range is that Although the normal range is generally defined for each of these, there are slight variations between laboratories and what is considered about differences, minor differences between blood counts at different laboratories. Basically, for a white blood cell, there's about 4,000 to 10,000 white blood cells per microliter, or in other words, this number would be 4 to 10. So as you can see, the result for this patient at this time on this date was normal at 9.2. But remember, when we report the white blood cell count, the white blood cell count has many components. Some of those components are normal cells, neutrophils, lymphocytes, and others. But also remember, if you are a patient with leukemia, that the leukemia cells will be included in that number of white blood cells. And so just looking at the number of white blood cells is only a small piece of the puzzle, small piece of the information. What's critically important are the types of white blood cells. So before talking about the red cells and the platelets, let's drop down to what we call the white blood cell differential. And that's shown in the lower part here of this blood report. What you'll notice is, again, abbreviations for the major types of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. These are the 5 major types of normal white cells that can be defined by a machine or by looking at these cells under the microscope. And again, these are the normal cells. What you're seeing here is the percentage of each of those. So you can see the most abundant white blood cell, accounting for almost 46% of the white blood cells, are the neutrophils. 39% are lymphocytes, and then less than that, smaller numbers of monocytes, eosinophils, and basophils. This person on this date has a slight elevation in the monocyte count, which, by the way, in this situation is of no clinical significance. Sometimes we see counts a little bit out of the normal range, and it's not to be concerning. But these are the relative numbers of the blood cells. And what's really important in understanding, for example, your risk of infection due to neutropenia is the absolute number of neutrophils. So we call that the ANC, absolute neutrophil count, ANC. And the absolute neutrophil count is obtained by taking this percentage, 45.7%, and multiplying it times the total white count. Because after all, 45.7% of all of the white cells are the neutrophils. And when you do that calculation, and fortunately for physicians, the machine does the calculation for us, 45.7% of 9.2 gives us the absolute number of neutrophils. Here on this readout is neutrophil number sign, and it's 4.2, or 4,200 neutrophils per microliter, a completely normal neutrophil count. When the neutrophil count gets below 1.5 or 1,500 neutrophils per microliter, we call that neutropenia, where you're starting to have a risk of infection. But the risk of serious infections really only occurs when the neutrophil remains for long periods of time, neutrophil count remains for long periods of time below 500. And the closer to 0 it is, obviously, the more devastating that could be for a person. And so a neutrophil count of 0.5 or 500 per microliter is called absolute neutropenia. There are normal numbers of lymphocytes too, so the relative number is not as important as the absolute number of lymphocytes. This is a normal number of lymphocytes. Now you might remember earlier I mentioned that the relative number of monocytes there of 13.1% is really not concerning to me. And the reason for that is the relative number is not as important to the physician and to the person with these blood counts as the absolute number, the actual number floating around in the blood. So when you multiply 13.1% times 9.2, the absolute number of monocytes is 1.2 or 1200 per microliter, that's well within the normal range. And that's why we weren't concerned about this flag here for the monocyte count. So again, in summary, what I want to mention here about the white cells is, number one, the white blood cell count, usually at the top of almost every blood count report, is normally between 4 and 10, or 4 and 10,000, 4,000 and 10,000 per microliter. And it represents all of the different white blood cells, both the normal white blood cells and the any malignant white blood cells that a person might have if they have leukemia. So acute leukemias, chronic leukemias, or even some lymphomas which can circulate in the blood, those cells may be counted as part of the white blood cell count. And so what becomes very important to your hematologist or oncologist is actually the relative numbers of these. In this person with normal blood counts, you can see the normal distribution of the types of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. The most important for you clinically are the neutrophils and lymphocytes, which are important in fighting infection. Let's move on to a discussion of how we measure red blood cells. Now, you remember I said that when the red blood cell count is low, we call that anemia, and when it's high, we call it polycythemia. And there are reasons for each of those, and it's your physician's responsibility to figure out in you why you're anemic or why you are polycythemic. On the report, we have 3 different ways of reporting basically whether you're anemic or not, or the red blood cell count. So let's look at that, okay? And they're usually reported in this order: the red blood cell count. So this is the actual number of those little orange circles I showed you on the last slide, the number of them per microliter. So this is 4.65 million, or 4,650,000 per microliter. Okay, so that's the normal number of red blood cells. But actually, what we typically as physicians concentrate on is not the red blood cell count, but the hemoglobin and or the hematocrit. And your physician and nurse may sometimes concentrate on hemoglobin, may sometimes use hematocrit. One's not necessarily much better than the other. In fact, there's an interesting relationship between those two numbers. If you look at the hemoglobin number, the hematocrit is usually about 3 times higher than the hemoglobin. It just turns out to be that way. The hemoglobin tells us how many grams of that protein hemoglobin are in every 100 cc's, 100 milliliters of blood. 100 milliliters is called a deciliter. So it's 14.5 grams per deciliter. The hematocrit is also called the packed cell volume. So sometimes you'll see it abbreviated HCT, sometimes you'll see it abbreviated PCV. Again, we apologize for the multiple names for the same exact thing. But you'll become used to it on your own reports, which one they're talking about. The hematocrit represents the volume of the blood that is occupied by red blood cells. So you might say, well, how can you figure that out? Well, actually, if you take a tube of blood and centrifuge it, in other words, put it in a machine that puts a centrifugal force on that tube of blood, the heavier red blood cells are packed to the bottom of the tube, and the plasma, the liquid portion, goes above it. We can measure then the percentage of that volume of blood that's accommodated by or accounted for by the red blood cells, and that's called the hematocrit or packed cell volume. Again, 3 ways of measuring the exact same thing: red blood cell count, hemoglobin, hematocrit. 3 ways of measuring the same thing. If those numbers are low, we call it anemia. If those numbers are high, out of the normal range, we call it polycythemia or erythrocytosis. Again, I did not give you normal ranges there because they'll vary from lab to lab, and they'll vary between men and women actually. But in general, somewhere between 12 and 16 grams per deciliter is considered a normal hemoglobin. Now below those three ways of measuring your red blood cells, RBC, hemoglobin, and hematocrit, you will also often find these next four: the mean cellular volume, the mean cellular hemoglobin, the mean cellular hemoglobin concentration, and the red cell distribution of widths. These numbers may be important to your physician to help diagnose what might be causing anemia, and that's why they're included. So if a person is sent to a hematologist with a low hemoglobin, each of those four numbers may give us some important clues as to the cause of the anemia. Those numbers may also change with therapy. So for example, a common finding that you may see on your blood count report is if you're receiving chemotherapy, the mean corpuscular volume or mean cellular volume often goes above normal, above 100. It's just a reaction to the chemotherapy that will go back into the normal range later. So I'm not going to spend more time on those, and unless your physician brings them up with you, I really suggest that you not pay much attention to those four numbers. They may just add to the confusion of this long report that you can see has quite a bit of information in it. Okay, let's now move to the last cellular component, and that's the platelet count. The normal platelet count is somewhere between 150,000 and 450,000. In this patient, you'll see that it's 148,000. This person was on a medication that suppresses the bone marrow's ability to make platelets and caused this person's platelet count to be a little bit low. It was flagged as low, and the R in our laboratory just means that the technician in the laboratory did review it, and that was the correct count. So 148,000, just a little bit below normal. So yes, I would say that this person has thrombocytopenia, a low platelet count. By definition, is below the normal range. However, that platelet count is not clinically significant on its own. In fact, with a platelet count of somewhere between 50 and 100,000, major surgery can be conducted without a significantly increased risk of bleeding. And in fact, in terms of spontaneous bruising or nosebleeds, we don't typically see that in people until the platelet count gets below 10 or 20,000. And so we have quite a bit of buffer, quite a bit of surplus of platelets to help clot the blood before clinical manifestations occur. Finally, what you'll see on these reports is the mean platelet volume. It is often elevated in people who are trying to make a lot of young red platelets in response to bleeding, for example, or immune destruction. But again, like the numbers that I pointed out for the red cells, MCV, MCH, MCHC, and RDW, the platelet volume really has very little importance to you as a person looking at your blood counts, but could give some information to your hematologist about what might be causing a platelet count to be on the low side. So those are your blood counts. This is obtained by passing the blood through a machine, and this printout is obtained very quickly. We can verify that the machine has adequately measured things and identified the different types of white blood cells, and make sure that the machine did not miss any abnormal white blood cells, for example leukemia cells, by actually taking a drop of that blood, smearing it out on a slide, and looking at it under the microscope, which is a common part of the evaluation of your blood. Okay, so those are your blood counts. And so what I hope I have shown you so far by showing you peripheral blood and showing you those blood counts is that each of the blood cells that we discussed have a finite lifespan. Red blood cells, 100 to 120 days. White blood cells, and specifically we'll talk about neutrophils, a matter of hours, not days, that they spend in the blood, and platelets somewhere between 5 and 10 days. And then they die. which means that in order for us to remain healthy, our bone marrow, the site of production of those blood cells, has to constantly be making new blood. And if the bone marrow stops doing that, the blood counts will go down because more cells are leaving the body through natural causes, that, living their lifespan and dying and not being reproduced. As you might expect, blood cells that only live for a few hours in the blood may be the most sensitive to things that turn off bone marrow function, like chemotherapy. And that's in fact why most chemotherapy drugs, when we think about their major side effect, it is in causing neutropenia, a low neutrophil count with a risk of infection. Some of these also cause a low platelet count or thrombocytopenia because, again, platelets only live for about 5 to 10 days. Significant anemia is less common, not impossible by any means with chemotherapy, but less common, and specifically can occur as you receive multiple cycles of chemotherapy because there's not enough time for the bone marrow to replenish the normal blood count before your physician may decide to give you more treatment for the disease that they're giving you care for. So let's look at what a bone marrow looks like. When a bone marrow biopsy is done, it will be done for a number of reasons. One of them will be to determine the cause of high blood counts or low blood counts, and another reason is often to see if a certain blood cancer, lymphoma, myeloma, or leukemias, is affecting the bone marrow and to what degree. So let me show you what we're looking at here. This is a section of a bone marrow biopsy. What's done here is a needle is inserted into the thick bone called the posterior iliac crest. It's part of the pelvis, and a core sample is taken out. That core sample is then decalcified overnight because it's bone, so that it can be thinly sliced and laid out on a microscope slide and stained. And that's what you're looking at here. This pink material is bone. We call it bone marrow trabeculae or spicules. The purple that you're seeing is a very low power magnification, so you can't see detail yet, of hematopoietic cells. Big word for the cells that are making your blood. And the round clear circles is fat. The amount of fat that is in a bone marrow will vary with age. And so this would be very abnormal if this was a bone marrow from a 10-year-old, where we would expect about 90% of the bone marrow space to be made up of the purple stuff. But this is relatively normal for a 70-year-old man, where about 30% of the bone marrow space has hematopoietic cells and the rest is fat. So let's look at higher magnification, what's happening in here. And what I'm showing you here is that higher magnification, you can see there are a variety of different types of cells. Again, here are the fat cells. Okay, this is a fat droplet inside an adipose cell. This is normal. Then there are various types of blood cells that we will see that make your blood. The most obvious that will stand out is this large cell with this funny nucleus here, that purple shape, and then the large cell here. If you recognize that one, then you'll see there's one here and then there's one here as well. Those are the three most obvious. Because they're larger than everything else, they're called a mega, for large, karyocyte, karyo because that has to do with the chromosomes in here, and there's extra DNA in those nuclei, and cyte means cell. Megakaryocytes, their job is to make platelets. What you can't see is at the edge of that cell, those tiny little platelets are budding off and going into the blood. The other cells that I can pick out here are the cells that have very dark circular nuclei, here and here and here. Okay, here and here, a few of them up here. Those are precursors of red blood cells. Those are the cells that will grow up and turn into red blood cells and then leave to go into the bloodstream. And then finally, scattered throughout here are cells with abnormally shaped, or not abnormally, but various shapes of the nuclei. And these are the granulocytic cells or the neutrophils and monocytes that are going to be produced. Those are the cells that make up your bone marrow. Now, there are a number of things that can happen to make your blood counts low. For example, if the bone, instead of a variety of cells, you see a monotonous infiltration of a lot of the same cells with very few of those megakaryocytes and maybe this island of red blood cell precursors. Now that I've made you all into very skilled pathologists, you can recognize the red blood cells there and the megakaryocyte. But most of the volume here is taken over by the cancer. There's much less fat in this older person. On the other hand, low blood counts can be caused by a number of other disease states. Just to show you one is aplastic anemia. Here is a bone marrow core section. Up here is called the periosteum. This is the cortex of the posterior iliac crest. And then this is the bone marrow core, again with these spicules or bone marrow trabeculae that I pointed out earlier. Now, this is from a 40-year-old person where I'd expect about half of this bone marrow to be made up of this dark purple hematopoietic cells, and you can see it's mostly replaced by fat. This can be due to chemotherapy, this can be due to radiation, this can be due to a number of diseases, including an autoimmune disease where our own immune systems suppress the bone marrow. And so what I've tried to show you very briefly is that a bone marrow biopsy will be done by your physician or requested by a physician to, number one, ascertain the cause of low blood counts. It's not always leukemia. There are pre-leukemic conditions. There are also conditions of viral suppression. There's aplastic anemia. So a bone marrow biopsy can be critically important in initially making the diagnosis of what's making the blood counts low. A bone marrow biopsy will be important in making sure that a treatment has been successful if the disease could be seen in the bone marrow, such as a leukemia or a lymphoma or a myeloma. So following the course of therapy, the bone marrow biopsy can be recommended. So there are a number of reasons for doing it, but what you need to remember is it's a remarkable organ. It is remarkable what our bone marrow does every second of the day. It is making blood. It's making 250 red blood cells, 250 billion red blood cells every day to replenish the 1% of our red blood cells that senesce and die and are destroyed in the spleen. It's making platelets and neutrophils constantly. And when diseases or the treatments that we use for cancers get in the way of that process, we develop low blood counts and can have the clinical results of those low blood counts. In the setting of a low platelet count, thrombocytopenia, we are worried about easy bruising and bleeding, nosebleeds, gum bleeding, bruises, heavy vaginal bleeding with periods. With a low neutrophil count, we worry about spontaneous infections, not getting the common cold more easily than someone else, but significant opportunistic infections of bacteria that already live on our skin or in our gut, or from fungi, the spores of which live in the air. And then finally, red blood cells being low, anemia, can give people symptoms of the anemia such as fatigue, shortness of breath, palpitations or a fast heartbeat with exertion, sometimes headaches. So what I hoped I did over this past video is give you some explanation of what your blood is made of, the cellular components, a little bit about the plasma, the liquid component, and the remarkable job that our bone marrow does in replenishing those blood cells every day of our lives to keep us healthy. Thank you.